So David deliberately shied away from my bio, which was less than traditional, and I purposely sent a bio in that doesn't doesn't sh- that doesn't share the usual discussions of how you describe yourself when you're in the medical community. So one of my pet peeves, and if you're going to come to the University of Utah and interview in our program, in any one of our programs, and we ask you to, or if I ask you to tell me about yourself, don't fall into this line of discussion of, well, I went to medical school here and I went to residency here and I did this research, because that tells me nothing about yourself. I think you're shaped by not so much the institutions that you go to, but the experiences that you have. And so I think the point being that when you talk about yourself, I like to hear the experiences that shape you as a person, because I think that dictates how you respond in a given clinical situation, or a given situation where you're dealing with people on fronts that are less than familiar. So I'm going to talk about how we as surgeons grow, and what drives us and what affects us, and some of the challenges that I faced in my career, and where I'm at now. I don't have any financial disclosures, but I do have a number of emotional disclosures that I think have developed this talk. There's been a moderate amount of emotional duress in my life. There's a number of mental health hours that I paid for that have contributed to this talk. There's a significant amount of legal fees, and probably a certain amount of moral injury, although I probably wouldn't admit that in any other venue. So study hard, learn more, be all. This was my mantra, and the mantra of two of my close friends, Ren Prasad and Paul Sislak, when we were medical students. And we were so narcissistic that we thought that we could just rule the world. We had gotten into medical school and like this was it. Little did we know what was going to happen. But we would use this mantra to motivate ourselves. We would use it in the anatomy lab when somebody one-upped somebody else on some obscure fact, or when we crushed the bell curve on our exams, we would just be chanting this, right? But as Paul moved over and progressed towards anesthesia, and Ren towards psych, he could understand why that mantra kind of fell away from them. But me, not so much. I still found myself uttering this mantra, which I'm sure you all have some form of this in your minds. The next steps is Paul went to anesthesia in the PEG, Winnipeg, for those of you who are not Canadian. And Ren went to psychiatry in Vancouver. I was in a situation where I had to make a decision about where I was going to go to residency. I had a spot in neurosurgery in Canada, but my fiance at the time was American, and we were pregnant, and because we weren't married yet, she didn't have healthcare in Canada when we were living together there. So we made the decision to move back to the States, and be closer to her family and get the medical care that she needed. And so you can imagine all the kind of tough decisions that I had to make at that time, being 24 years old and trying to figure out my career path and having a young family and navigating insurance. And this was a pretty big challenge for me. And gave up a spot in neurosurgery in Canada to come to the United States and not have any spot. So I took a year off, my son was born, and I was a stay-at-home dad for the first year, which for me, the way I'm wired, was a very difficult thing for me to do, but I think a pretty significant growing opportunity. And had to figure out what I was going to do for residency in my career. I gave up on the notion that I was still going to do neurosurgery. I felt like I didn't have the CV for it. I was coming from Canada. I was not a known commodity, but I definitely still wanted to do surgery. And so I applied to surgery at a few places. And my wife at the time had gone to UC Santa Barbara, and said all these great things about it. And so I looked at Santa Barbara Cottage Hospital, which is pictured here. And they gave me a spot as a prelim. And I actually also, because I just wanted to, at that point in my life, be back into medicine and figure out how I was going to be a physician again. I'd also applied to medicine. So one day I had my interview with the internal medicine group, and then the next day I had my interview with the surgery group, and that was kind of weird, trying to talk out of both sides of my mouth just so I could try and get a spot. And medicine offered me a residency, and surgery offered me a prelim spot. So what did I do? I didn't take the sure thing. I took the prelim year, and because that's where my passion lied. Fortunately, things worked out, and moved into a categorical spot and completed residency. But you can imagine how stressful that first year was for me, because this was kind of a make or break kind of deal. And so internship by itself is pretty stressful. And then my wife and my child, who was about 1.5 at this time, barely saw me, created a lot of strain, made it into residency, and then things progressed from there. Residency continued to be a challenge, as those of you who are residents or have gone through residency know. There's a lot of ups and downs. This was a great place to train. We were the only surgical residency at Cottage Hospital, but they delivered surgical care across the breadth of surgery: orthopedics, neurosurgery, OB-GYN, ENT, and we scrubbed all of it. So I had a really great basis for surgery in a lot of different surgical subspecialties. But when I think back to those days, I still have some fond memories, but then also some memories that are what I would say still sit with me, but in not so good a way. So I think many of you can probably remember a complication or an event with a patient that really never leaves you. So, halfway through my residency, one of these things happened, and there was a complication with a patient, and I felt squarely responsible for that complication. I felt that this was something that I had missed. And, I talked to my wife about it, and she said all the right things. She was consoling. She said, you shouldn't beat yourself up about it. This could happen to anybody. This is part of, maturation and becoming a physician. And I would have none of it. Like, I was like, you just don't understand. And how could she, right? She wasn't in the medical profession. She didn't know what I was feeling and what I was grappling with. And, the feeling that, can I do this work? Can I be a surgeon when something like this happens? So I tucked what happened away, tucked that patient away, moved on. Residency, you're just constantly moving. You don't have time to process. You're just on to the next thing. But that thing was still sitting inside me. Who knows who this is? Anybody? Lariche, René Lariche, French surgeon, vascular surgeon, known for Lariche's syndrome, which is iliac claudication. So Lariche had a quote that's really struck me. He said that each surgeon carries within himself a small cemetery, a place where he goes from time to time, a place of regret and bitterness, where he must search for explanations for his failures. And when I read that, it sort of brought back that complication and that place that I went to when I had that complication. And unfortunately, that's a place that I've been to a few more times since then. But I thought when I read that, this is sad, it's depressing. And I thought, I'm probably not the only person. I'm sure all of you have that place in your mind where you go when something like this happens. But I also thought, this is sad because of how siloed and how isolated we, I think, as surgeons become when something like this happens. And I look at how our residency is at the University of Utah and how we're trying to combat this. Everybody, I'm sure, is aware of the data on how suicidal ideation is high amongst surgical trainees, and how do we deal with something like this? We had nothing like that in our day. Like, who do you talk to with, because of how you're feeling about what happened. You try to suppress it. You don't want to openly share it. Um, there's guilt, there's shame around it. And it was when I read this quote, it really resonated with me. And I think it probably hits a chord with some of you. So, but that gets to why do we have this kind of attrition in general surgery training? There was a study of international surgical trainees that found that attrition rates were 18%. So this is not just something that's in the United States, this is globally, this is international surgical trainees. And when you look at rates of attrition in the US, they range anywhere from 5 to 30% in surgical subspecialties. And I think this has a lot to do with the strain of the job. And in fact, when you look at meta-analysis of 10 studies on attrition, do you know what the number one reason for attrition was? Anybody? Trainees. Uncontrollable lifestyle. So I joke about this with my partners because many surgeons are control freaks, but when you actually look at your job, you have very little control of what you do. Certainly as residents, and just as much I would say in faculty, it's just a different set of parameters that you're able to control or not control. And so it's not surprising that we select, I think, a group of people who feel the need to control things, who desire it because that's what they feel that needs to happen for the care of their patients. But we thrust them into an environment where they don't have that control. And it's schizophrenic, right? You must control what's happening with your patient, but you can't control anything in your life as a result. So what are some of the other reasons for voluntary attrition? There was another survey that was done that identified that not only is it a lack of control, but there's the excessive work hours, there's the strain of the job, and then there's the strain on family life. So this survey identified that these three parameters came up time and time and again in terms of why people leave surgery. And then there was another survey that identified that there was a distaste for the personality that was felt needed to be a good surgeon. And so you can quibble about whether or not that personality is an issue more with neurosurgery versus general surgery versus CV surgery or whatever. But suffice it to say, I think that there is a certain personality type that is associated with being a surgeon. I think we all know it, whether or not we can define it. But there's a dissatisfaction with what that personality type is that leads to people, or at least the perception of what that personality type is that leads to people leaving surgery. So knowing that these are the reasons, some of the top reasons for why people leave surgery means that we have to focus on these things to try to prevent attrition, to try to improve satisfaction with what it is that we do. And there's been 8 studies that were brought together to sort of summarize what are some of the themes or some of the interventions that can help prevent attrition. One of them is to journal. And this is something that's pretty commonplace in mental health therapy. Journaling to kind of bring out and focus in on some of the things that resonate with you in your job, in the care that you're delivering. Maybe it's an interaction with a patient, maybe it's a case that you did, but something that resonates with you that brings meaning to the work that you're doing. Because I think that this is important, whether you choose to write this down or to reflect on it personally or to take some time out to do this. This is an important thing to do because it brings the humanity of medicine back into play. And you have to stop and take a breath to do this every once in a while, because otherwise you don't have time to process. And if you don't have time to process, these things fester, and it can lead to further dissatisfaction in your life, and you lose sight of why it is you're doing what you're doing. Being prescriptive in the things that you're doing. a mental exercise of preparing for a case or running through scenarios, trauma scenarios, or what have you, a clinical scenario of a certain kind, mentally doing that to prepare yourself for something that could be coming up in the future is another exercise that seems to help. One of the things that came out of this review was that there is a real lack of self-awareness in surgery and among surgical trainees. Having something in your program that allows for the identification of psychological stress or emotional duress is really important in order to identify when problems are occurring or when you're struggling. And because of the nature of the work that we do, we lose that self-awareness. We get caught up in the things that we have to learn, the tasks that we have to do, the operations we have to prepare for, the struggles of our patients, and it leaves little for us. But really, those things are important for us for longevity and for our own mental health. So my saga continued. I finished residency. One of my mentors, Ken Waxman, who we were just chatting about last night, who was a trauma surgeon and a basic scientist, I think he was instrumental in shaping me and who I am as a teacher, but also as somebody that I looked up to and somebody I wanted to model myself after. Was very helpful, I think, in me getting a fellowship from Santa Barbara Community Hospital to Harborview, which is probably one of the most sought after fellowships in the country. So I think I count myself very fortunate to have been able to train there for fellowship, where I met these two individuals who were also, I think, pivotal in my maturation process. Ron Mayer and Jerry Jerkovich, who were two people that I would say really had their stuff together. Academic superstars, great surgeons, but not only that, just great people. Like, to talk to these two individuals, they were just so personable and not detached, which was refreshing to me, really, quite honestly. So I finished fellowship and then took a job in Boston at one of the Harvard hospitals and was there for a short period of time. That was not a good job when you're coming out of a busy trauma center like this, because BIDMC did not get a lot of trauma and their surgery was very highly subspecialized, and so I was sitting on my hands. So you never want to be a new surgeon not operating. That's a recipe for disaster. So we didn't stay there very long. We then moved to Milwaukee, where I was fortunate enough to be mentored by John Weigelt, who also another great human being, really a fantastic surgeon, very bright, and a phenomenal surgical educator. So when I got here, Milwaukee Medical College of Wisconsin, very busy penetrating trauma center. I was operating there like crazy. I was operating at the VA. They had great research going on, and I was busy. Like, I was thrilled, but I felt like I had to really prove myself there. And in doing so, as time went on, really my marriage suffered. It suffered a lot. I was not at home very much. I was very busy. Arguments, unhappiness at home, and this led to a lot of problems. And one day in particular, we had a pretty heated argument, and I was about to do a lap adrenalectomy. And if I'm honest with myself, I think that I shouldn't have operated that day. My head was not in the right spot. And unfortunately, there was a complication where I did not realize I had injured the pancreas during the dissection, had to take the patient back 3 days later. The patient did okay, but I went back to my small cemetery that day. And I think it's these kinds of moments where you find that the trouble that we have in surgery and what we do, the impact that we have on our patients is so great. And if we can't create separation between what's happening in our personal lives and what's happening with us and our patients, that can lead to real problems. So what happens when you have an adverse event like this? What happens to you? There's been some work on this as surgeons as the second victim syndrome. The pain of unexpected and tragic deaths lingers with physicians. And so this was a survey out of Boston of 126 surgeons who had suffered had incurred an adverse event in the operating room. And they surveyed them to find out what were the sort of the feelings that surgeons would perseverate on when this happened. And not surprisingly, there's a lot of anxiety, a great deal of guilt, sadness, shame, embarrassment, and anger even. When we dive into these kinds of emotions, and then you put a surgeon in a situation where day after day they may be faced with the same kind of thing, it's not an excuse for how they might behave in the operating room, but then you then start to understand why surgeons might be acting a way that they shouldn't in the operating room. And I'm sure all of you have heard or even seen surgeons who don't behave in a professional way in the operating room. There's a number of things that drive that. And I think this is at play in some of those situations. And I think that when we see that in the operating room, it's an opportunity to work with that person, to get at what is underneath all of that that makes them do the things that they're doing. I think it's on us as surgical leaders to, when we see that, to try to dive into that and get them the help that they need. 42% reported that colleagues, rather than friends and family, provided the most helpful support. This resonated with me because it brought me back to the idea that when my wife was trying to tell me how, don't try and get over this, I couldn't accept that. You have to be with somebody that can commiserate, that can understand, that can be there when these kinds of things happen. At least that's how I feel, and that's how 42% of this survey felt. But it also brings up the other important point that we don't do a good job in training to help our trainees prepare for what's about to happen when they become attendings. It's a little bit different when you're a resident, right? Yes, you're getting graduated autonomy. Yes, you are taking care of the patient. But in the back of your mind, either consciously or subconsciously, there's an attending behind you. And the responsibility ultimately falls to that attending. And so you may take this pretty seriously when something happens that shouldn't happen. But the emotional results and the toll build up over time, and it's different when you're an attending. It changes, things change. And I think that emotional response amplifies. The pressure increases tremendously when you make that jump from one day being a resident to the next day being an attending. And I don't think that we as a whole do a great job in preparing our residents for that, because the thing that's so challenging is that many of us have tied our identity to being a surgeon and our professional identity to the outcomes that we have. And even if we don't do it ourselves, everybody else is doing it to you. I mean, how many of you have heard at the OR front desk, if I'm in a trauma, I want so-and-so, I want Spain to be on call, or I want so-and-so to be on call if I'm going to get injured, or if I get cancer, I want this person to be my surgeon, right? That's uplifting to that person. It puts a lot of pressure on that person, but it's a description of how our identity is tied to our surgical outcomes, right? You have a reputation, and if you don't maintain that reputation, that's obviously not good for your patient, but it takes a toll on you yourself. And so because of that, the emotional toll and the psychological stress that happens as a result of having a poor outcome is devastating, because our identities are so tied to that. We don't do a great job in preparing our residents for that or addressing that when it comes up. So that brings us to, what does it take to be a good surgeon, right? Like, do we have to have great outcomes? We have to have a vast medical knowledge. We have to be decisive sometimes very quickly in the line of work that we do. We have to be compassionate. We have to be technically skilled, be masters of surgery. Those are all things that we aspire to. These are all things that when you look at your surgical leaders, that many of those traits they have, and we elevate those traits. When you look at the psychological definition of workaholic is actually a DSM diagnosis, but it is the one of the few psychological diagnoses that are socially applauded, right? In every level of society, if you're a workaholic, you're thought of as being like, well, like, that's a positive, that's not a negative. You know, but it actually is something that destroys lives and kills people in the extreme. So does a good surgeon need to be a workaholic? When you look here at this amphitheater, you've got all these minds looking down at this person who's about to perform surgery, and what an aura in a theater that is. But what else do we have to balance that with? Does being a good surgeon mean you have to be a workaholic? Or does being a good surgeon mean that you also have to balance that with fulfilling relationships, hobbies, having a relationship with a partner or children, or something else besides just surgery? These are questions that I think are very specific to the individual, and what you need in your life to make you be a good surgeon really is different from one person to another. But when I tried to search on the internet what happy doctor looks like, I got Dr. Huxtable and Gray's Anatomy. So the point being is that there's not one definition for happy doctor, and it's personified on TV, but who knows what that is for you or you or you. But it's probably not, I would say, being a workaholic for most of us. There probably needs to be something else in our lives that helps us get through the stuff that we do during the day in and day out of surgery. So it got me thinking about this idea of the duplicitous nature of surgery, where in order to be a good surgeon, you need to be a workaholic, and you need to always be available, and you need to always do the right thing. But yet we're still human and we make mistakes, and how do we deal with that? We work in a world where we have to be in control, but our jobs don't let us control our own lives. We work in a world where professionals get paid millions to throw a ball, but we have to lobby with government to save millions to throw a stitch to save a life. We work in a world where our jobs require us to strive for perfection, but we have to be tolerant of people who are perfectly satisfied to just do the job. We work in a world where terms like work and wellness are battered around sometimes by people who have the luxury of being well and don't have to work that much. We work in a world where we have to balance on a tightrope with work-life balance. That's so challenging sometimes. One misstep can lead to the whole tent falling down around us. We work in a world where we might do the right thing for the right patient at the right time and we'll still get sued. We work in a world where when we do the right thing for a person and we make them feel better and it gives them their life back, work-life balance takes on a whole different meaning. So, Medical College of Wisconsin, challenges with my marriage, went to both individual therapy and couples therapy, but my wife and I were never really in sync. We weren't on the same page at the same time. We didn't want the same things at the same time. We weren't ready to work on our marriage when the time needed it at the same time. But I did learn a few things about this drive that I had to try to pursue mastery, and why was I doing this? And there's a number of reasons why we do what we do in surgery. Ultimately, for the patient benefit, we feel responsible for our patients. We need to know as much as we can know and need to be technically as good as we can be to make the right decision at the right time. It's tied to my identity. There's no denying that. Self-esteem, fulfillment, these are all reasons why we pursue what it is that we do. But it comes at a cost if it's excessive. It leads to loss of relationships. There's the loss of self-awareness, the loss of objectivity, unrealistic expectations of others. And we see this manifest every day if you actually look at the people around you and you think about why they're behaving the way they do. It has a lot to do with it. But maybe the millennials and the Generation X have it right. Their choice of careers is not as based on the same things that my choices were made on, or David's, or people that are in a different generation. They tend to, and I'm speaking in generalities, weigh time and money differently. And they look at things like length of training and the availability of being able to balance time in the job and time with other activities, and to have a multi-dimensional life. There's less of a sense of vocation of just working long hours in substandard conditions, which I think we as surgeons in my generation and the generations before did to our own detriment. And it's led to challenges that we face now when we talk about how we staff, with how many surgeons do we need to staff, say, an acute care surgery group? Is it 4? Well, yeah, it's 4 if you want to be on call a lot and make more money, if your salary depends on how clinically busy you are. Or is it 6 or 7 or 8 so that you can have a lifestyle and accept the fact that you're going to have a lower salary because somebody's got to pay for all those surgeons? Going to result in a decreased medical workforce. What are the effects on training, on skill? I think that's still yet to be determined. Will it translate into differences in patient outcomes? So I did learn a lot in the last few decades of my career, and I still am a very active surgeon, and I think that I still have a lot to contribute. But here's the sharp truth about the last few decades of my life. I had a great residency, a great fellowship. September 12th, 2016, I separated from my wife. Worked at a Harvard hospital, great. I felt that I had failed my kids, failed my marriage, failed my kids. Gained experience at several busy trauma centers, moved into a crappy condo, published tons of papers, now have my daughter a few days a month. Leadership positions in national societies. When we first separated, I would cry in my crappy condo anytime that my daughter went back to her mom. Trained hundreds of residents, med students, and fellows, lost 30 pounds, gained that back, as you can see. Gained the respect of my peers, never sought help and counseling when I think I needed it the most. From a medical director, dealt with lawyers, constant battling, a 3-year-long divorce. Chief of Division of General Surgery, finally divorced 2019. Life's different for me now. That's 4 years ago. I think I have a pretty enviable position as Chief of Division of General Surgery. I'm privileged to work with 38 surgeons in my group who are phenomenal people. And that makes my job much easier. I'm fairly administrative now, and I get a lot of fulfillment out of helping my faculty develop and grow, helping residents develop and grow. And I'm in a position where I think that I can influence some of the things that I had to deal with, but didn't have the help that I think I should have had. I'm no longer feeling like I need to be a perfectionist. I still strive for excellence for my patients. But I would say that I've taken a path now where I'm with somebody with whom I can enjoy life more. I have hobbies. I have some other interests. I think that's helped me a lot. in this next phase of my life. I'm no longer feeling the need to do those big cases because I have to prove something. I'm certainly there for my junior faculty to help them do those big cases when they need it, but I don't need it. And I'm fully aware of the fact that I'm at that stage now because I've already done all this, and maybe if I hadn't, I'd still be in that phase. But I think we have to figure out how we can still feel value in what we do as surgeons and not have it tied so tightly to our outcomes, and that we're doing these giant cases, and that is who we are. So to my friends Ren and Paul, I think I have to amend the motto a little bit. Keep studying hard, keep learning more, but accept the fact that you can't be all. Because once you can do that, I think you can then determine who you need to be. So I want to thank you all for your time and for giving me a moment of self-reflection.